what is muscle damage, what are the possibilities to identify the severity of that damage of muscles, especially skeletal muscle, cardiac muscle, and other soft tissues. Yes, there are other way also. Yes, sometimes we do X-ray to see the fracture and the tendons, and even we do some ultrasonography and MRI, CT to see. But for many things, especially these cardiac tissue damage, we prefer biochemical marker and electrocardiography. And we said electrocardiography is a very specific, but that is not very sensitive. That's why we need sensitive tests which are available in the biochemistry. And we learned that CK, SGOT, LDH, these are some biochemical tests which can reflect the degree of destruction of the cardiac tissue after myocardial infarction. And last time we also learned why these markers increase, how they increase, and there is a possibility of decrease also in some disease. There are some other markers as well. Yesterday, another very important marker that is called cardiac troponin. Troponin is a special type of protein, and we are saying cardiac troponin. Yes, it is present in other muscle, but we are saying cardiac troponin. This is very, very specific for only for cardiac tissue. That's why we are saying cardiac troponin rather than just troponin. They are not enzymes. See, before this, we discussed CK total and CKMB, LDH total, SGPT, SGOT or AST. These are some cardiac enzymes, or they increase when there is a destruction of cardiac tissue. Out of this is fourth one, which is cardiac troponin. This is not enzyme. This is just a protein. And however, they are accepted as a marker of myocardial infarction. Not accepted only, this is the most specific one marker available in the market, and everywhere we are doing this. We along with CKMB and the troponin I, we are doing frequently these tests in almost every hospital. These are available if there is some kind of facility for detection and management of myocardial infarction or cardiovascular disease. The troponin complex consists of three components. That means it has three different types of troponin. Troponin C, that is related to calcium, or it binds with calcium, that is called troponin C. Another is troponin I, that is related to ectomycin ATPase inhibitory element. That means it inhibits that ectomycin. That's why we said troponin I. And the next one is troponin T, tropomycin binding element, that T for tropomycin T. These are the three troponin types. So we generally measure troponin I. However, troponin T is very sensitive again, but this is a little bit expensive compared to troponin I. That's why we are frequently doing troponin I in the clinical setup. And the best part of this technology-derived era is that nowadays this troponin I are available in POCT. That means point of care testing device. That means we can do by ourselves in our home, or as well as in a small clinic or emergency room. Like many women can do pregnancy test at their home. Similarly, we can do this troponin test at our home also, just to see it's positive or negative. Just need one drop of blood and just put one drop of blood in that cassette, and after 15 minutes you can see whether it's positive or negative. However, in the laboratory we can measure how much is it. That is called quantitative test. That means many tests are either quantitative or qualitative. Quantitative means we measure how much it is present in our body fluids. Quantitative means just it is present or not. Like generally HIV test we do, it is HIV positive or negative. If there is a positive, then only go for what is the amount of CD4 cells, like that. Those are quantitative tests. But generally qualitative tests are very, very enough to just rule out whether there is some problem or not. Similarly, this troponin I is available in that simple POCT, like pregnancy test, and anyone can do. Yes, cardiac troponin I is released into the circulation within 4 hours. See, we said CKMB also released in 3 to 6 hours. That means sometimes CKMB is high, troponin is negative. That means maybe there is a limitation of time or something like that. Suppose patient come to your clinic with within 2 to 3 hours of chest pain or one set of myocardial infarction. That time, if you send both CKMB and troponin I to the clinical biochemistry laboratory, that time you may get high value of CKMB and troponin I negative. That means something is still happening inside the patient of that body of that patient. And after a few hours, if you send 1 hour later or 2 hours later, if you send again sample, maybe that time you find troponin also positive. Peak is observed in 14 to 24 hours and remains elevated 3 to 5 days of post-infarction. See, that means generally CKMB was peak in 24 hours and come normal in 48 hours, but we can see 3 to 5 days it is still running in our blood. Serum level of troponin T increased within 6 hours of myocardial infarction, peaks at 7 to 2 hours and then remains elevated up to 7 to 10 days. I said troponin T can be measured. This is more sensitive than troponin I, but that has again limitation because it start releasing in the blood after 6 hours of myocardial infarction. That means it's not that much easy to hold the patient for 6 hours in emergency room for this test only. And the peak is in 72 hours. And the best part of this troponin T is, suppose a patient come to your clinic after a week of his chest pain due to some like this lockdown situation or other any situation. That time the patient giving history is frankly like myocardial infarction, but that time you don't have a choice to see CKMB or very acute marker because they are already disappeared or they are already normal. That time you can measure troponin T, and if it is high, that means you can say, yes, you had a myocardial infarction a week ago. Like that we can diagnose. The troponin T2 estimation is 100% sensitive index for myocardial infarction. See, I told you this is very, very sensitive, but it's not that much easily available as a troponin I. And 51 marker after troponin I, that is myoglobin, is a cardiac marker. Myoglobin is a marker of skeletal muscle also. That's why we are saying myoglobin is a cardiac marker here. One of the earliest marker is myoglobin. Remember this line because this line is the very important question for MCQ. Generally ask which is the most sensitive marker or which is the earliest marker of muscle damage. That time we put myoglobin, LDH, SGOT, SGPT or troponin. That time you have to remember myoglobin is the earliest marker, which is very sensitive, but it's certain in certain clinical setting lack specificity. That means it's very, very sensitive. That means if a small amount of muscle damage, it starts increasing our blood. But we don't know which muscle has a problem because it is also available in skeletal muscle. It is also in the cardiac muscle. That time it's very, very difficult. Well, is the problem. But it's a very, very early marker. It's nearly, we can say within an hour of muscle injury, it start increasing. Its level rises 2 to 4 hours of infarction. Firstly, high levels may be observed in patient of renal failure or patient having muscle injuries. See, if some people have a heavy exercise or some other injuries due to trauma, that time there is a false positive, risk of false positive because we don't know what is the reason behind this high value of myoglobin. That's why it's sensitive in the sense because it's the very earliest marker. And even very small or very few amount of muscle damage, it reflects easily. And the very earliest, because 2 to 4 hours, we say 1 to 2 hours even, sometimes we can find 1 to 2 hours it increase in the blood and the urine as well, because it is acted through urine also. But it is not specific because specific means we don't know whether it's related to cardiac muscle or skeletal muscle or other any tissue. That's why we are saying it has a low specificity but very high sensitivity. After that, now we just to try to remember, there are at least 5 markers, biochemical markers, which are frequently requested for the diagnosis and management of myocardial infarction or heart attack. That is CKMB, troponin I. These are the most specific and sensitive one. Then we can go for SGOT, LDH, and myoglobin. These are the 5 markers we generally prefer to test in our clinical biochemistry laboratory for the diagnosis and the management of myocardial infarction, along with other markers like ECG or something like that, or in the clinical history. Of course, that is very, very important. Without clinical history, how you advise for biochemical markers. That's why a genuine history is very, very essential. And taking history is a type of art. Sometimes people hide history. That time you have think smartly how you can get the exact thing, exact or the true history from patient. It's sometimes tricky because patients lie many times. One month ago, we have one patient in our emergency room in Dhulkil Hospital. They denied that they were never exposed to anyone. They are not coming from abroad, but finally she died, and the diagnosis was suspected coronavirus. However, that was not confirmed later. But later we know that old lady has a daughter staying in the Germany or something like. She just came back to Nepal and they're staying with her. That means when we asked history, she had that she said she has no one who recently visited from the abroad or any risk zone. Like that, patient hide history. That time history is very, very important, and we have to develop some skill. How can we take all truth history from patient and their relatives? Yes, after that, that cardiac markers, we have serum enzymes in liver disease. That means marker of liver disease. Yes, we many have heard that liver function test. Liver function test, or LFT, we say LFT. There are many, many enzymes and other markers to see how liver is working or not, or how much problem in the liver. Serum enzymes test can be grouped into 2 categories: enzymes whose elevation in serum liquid damage to hepatocytes. That means if such enzymes, if they are higher than biological reference range. And second one, enzymes whose elevation in serum reflect cholelithiasis or cholestasis. That means stone in the gallbladder, because that is the most common disorder of liver. Enzymes that reflect damage to hepatocytes, aminotransferase or transaminase, both are the synonymous word. These are sensitive indicator of liver cell injury and are most helpful in the recognizing acute hepatocellular disease such as hepatitis. These includes AST and ALT, or sometimes AST also called SGOT, ALT also called SGPT. These are 2 enzymes which increase very, very high in acute situation like acute hepatitis or viral hepatitis, like that. In these conditions, it is very, very high. And these are the enzymes which are frequently measured in clinical laboratories to see the status or function of the hepatocytes. Aminotransferase or AST is found in the liver, cardiac muscle, skeletal muscle, kidney, brain, pancreas, lungs, leukocyte, and erythrocyte in the decreasing order of concentration. That means that the highest concentration of this AST found in liver, then that is cardiac muscle, also skeletal muscle, kidney, brain, many tissues release this enzyme. However, the highest concentration is found in the liver. That's why we are saying this is for liver function test. Normal biological reference is 5 to 40 international units per liter, and it found primarily in the liver. Yes, the highest concentration of this enzyme is found in the liver. Normal level of this ALT is almost same like ALT, AST, both are almost same, 5 to 45. For your comfortable or convenient, you can just remember 5 to 40 for AST as well as ALT, because it doesn't matter if you say a little bit low or a little bit high value. But basically, you have to remember unit, because unit matters. Because sometimes we ask it the kilo or milligram or kilogram or liter, it's difficult. So that's why it's the international unit per liter. And the aminotransferases are normally present in the serum in low concentration. These enzymes are released into the blood in a greater amounts when there is a damage to the liver cell membrane, resulting in increased permeability. That means if there is any kind of injury in the hepatocytes, that time these SGOT or SGPT or ASTLT enzymes are little bit high. Sometimes they are high in 20-25 folds also. That's why these are very good or sensitive marker for hepatocellular damage. Diagnostic significance of aminotransferase. How we interpret these tests or enzymes. Level of up to 300 unit per liter or international unit per liter are non-specific and may be found in many types of liver disease. That means we said these SGOT and SCPT or ASTLT enzymes are normally 5 to 40 or 5 to 45 international unit per liter. But up to 300 international unit per liter, it doesn't signify that it has this type of disease. There is something wrong is there, but we can't say that this is the main reason. Striking elevation of these aminotransferase, such as more than 1,000 international unit per liter, occurs almost exclusively in disorders associated with extensive hepatocellular injury, such as viral hepatitis. Yes, if someone has a viral hepatitis, that time the value of these enzymes, especially ASTLT, they are more than 1,000. It's very, very easy to predict, yes, the patient suffering from hepatitis or viral hepatitis. And the ischemic liver injury, prolonged hypertension or acute heart failure or toxin or drug-induced liver injury, these are some diseases which are related for very high value of these AST and ALT. In most acute hepatocellular disorder, the ALT is higher than the AST. That means because AST is also found in the cardiac muscle, skeletal muscle. However, SGPT also found, but in the hepatocellular damage, concentration of ALT is higher than AST. No, in obstructive jaundice, the aminotransferases are usually not greatly elevated. That means, suppose a patient having cholelithiasis or gallbladder stone, that time there is a Oh, someone asking, sir, if patient lie, they don't want actual treatment, what could we do? Yes, we will discuss that also. How, because sometimes, yes, patients don't want to treat because they are fear to society or they are fear to their child, because sometimes cancer patients denied most of the time, no, I don't want to get any treatment, just leave me alone, let me die, like that. But still we have some sentiments, so we have to try our best. It's not very easy, like a question, it's not very, very easy. It's very, very difficult because patient lie. Even we lie sometimes. We know if we have a mild pain in our teeth, no, it's okay, it will come fine tomorrow. We are not going to see very easily to dentist because we don't want to go there and they will say, no, you have a problem in 3 or 4 teeth or something like that. That's why many people deny this. But this is our responsibility, how we can make them happy and ask all the truth about that. But we will continue to discuss this later. Yes, in obstructive jaundice, these aminotransferase enzymes, especially SGOT, SGPT, or ASTLT enzymes, are not very high because these are obstruction is not directly related to hepatocytes. That is obstruction in the gallbladder, and that means these cells are not hepatocytes. That's why these enzymes are not very increased in cholelithiasis or that gallbladder stone or obstruction. Next, enzymes that reflect cholestasis or cholelithiasis, that means that stone formation. The activities of 3 enzymes, alkaline phosphatase, 5-nucleotidase, and gamma-glutamyl transpeptidase, GGT, are usually elevated in the cholestasis or cholelithiasis. That means, see, we have different types of liver disease. And the most common one liver disease is jaundice. We know, we have heard this word jaundice very well. And in GI hepato, we will discuss how bilirubin synthesized, what are the types of jaundice, what types of jaundice is related to what, like that. But here we are focusing some markers of tissue damage. That's why if there is damage of hepatocytes, which are the cells of liver, then we will measure SGOT and SCPT. But when we think that there is no problem in the liver, there is a problem in the nearby or adjacent cell of or tissue of the liver, such that it happens when the cholelithiasis or obstructive jaundice, that time these three enzymes are elevated, especially alkaline phosphatase, 5-nucleotidase and the gamma-glutamate transpeptidase. But it's difficult to say that without examine, we don't know where is the problem actually, either in the liver or after liver. That's why we go for LFT, liver function test. That time we measure all the enzymes which are related to hepatocytes as well as in obstruction. Alkaline phosphatase and 5-nucleotidase are found or near to the bile canal membrane of hepatocyte, while gamma GT is located in the endoplasmic reticulum in the bile duct of epithelial cells. See, I told you these are not hepatocytes; they are adjacent to the hepatocytes. That's why if there is any obstruction, that obstruction causes the necrosis of the cells nearby, and they release these enzymes in the blood, and they increase very high. Alkaline phosphatase in liver disease. The normal serum alkaline phosphatase consists of many distinct isoenzymes found in the liver, bone, placenta, and less commonly in small intestine. That means it has some isoenzymes, and they are related to bone and placenta. That's why during the pregnancy, this is very high. Young child who are growing age, they have very high alkaline phosphatase. However, they have no liver disease because it is present in bone, and the bone are growing continuously in the young children. That's why it's very, very high in young children and during the pregnancy because placenta releasing this enzyme. That's why if we want to identify the problem, we must have some idea about physiological changes also, like I said, during the pregnancy, and during some cases, if there is a cancer patient suffering from some bone cancer, that time it will be high, and that time you have to think, no, it is also released from the bone, that's why it's not related to liver, this condition. You have to know some physiological condition as well. Yes, physiological variation. Patient over age of 60 can have a mild elevated alkaline phosphatase because the bone starts decaying in the age of 60 or 70. That's why mild elevation of alkaline phosphatase is possible. It is also non-pathological elevated in children. I told you because they are growing and the bone are growing rapidly. That's why this alkaline phosphatase is high in the blood. It is also high in late normal pregnancy due to the influx of placental alkaline phosphatase. Yes, these are some physiological conditions. These are not pathological conditions because growing child or aging or pregnancy, these are not any abnormality or not in a pathological condition. And similarly, we have pathological conditions. Elevation of liver-derived alkaline phosphatase is not totally specific for cholestasis. That means it's not only elevated in the that obstruction due to gallbladder stone, and a less than threefold elevation can be seen in almost any type of liver disease. That means it may be double or triple of this normal value can be obtained in other liver disease. Even patients are chronic alcoholic or hepatitis. That time also it increased, but the very high value are obtained in the obstruction. Alkaline phosphatase in liver disease now. In liver disease, the elevation is almost always due to increased amount in the liver isoenzyme. Extrahepatic cholestasis is a very high value are found in obstructive jaundice due to cancer, common duct stone, splenomegaly or bile duct stricture, or cholangiocarcinoma, or many diseases are there. Cholangiocarcinoma is very common, and 1 or 2 years ago, that Dr. Bhagwan Koirala, Dr. Upendra Devkota was suffering from this cholangiocarcinoma, and that was the carcinoma of this colon and the pancreas head, that is cholangiocarcinoma, that causes jaundice ultimately. The level of serum alkaline phosphatase elevation is not helpful in distinguishing between intrahepatic and extrahepatic cholestasis. Sometimes it's very, very difficult to differentiate the disease on the basis of only this alkaline phosphatase. However, it's helpful, but on the basis of single result, you cannot say the patient have a problem in this particular site. It's very, very difficult. That's why we have to go for multiple tests, multiple time, and multi varieties of tests. And some isoenzyme of alkaline phosphatase, hepatic isoenzyme, it's a level rise in extrahepatic biliary obstruction if there is obstructive jaundice or obstruction due to some tumor or something like that. Bone isoenzymes increases due to osteoblastic activity and normally elevated in children during periods of active growth. That means they are increased in young children and especially when these osteoblastic cells are decaying in old age. Similarly, placenta isoenzyme rise during the last 6 weeks of pregnancy, and intestinal isoenzymes rise occur after a fatty meal, may increase during various GI disorders. Yes, these are some regions where we can find total alkaline phosphatase may high due to particular or very specific isoenzymes due to any isoenzymes. Maybe it relates to hepatic or bone or placenta or intestinal isoenzymes. Whatever is increased, the total will be increased definitely. And after that, gamma glutamyl transferase or GGT, it is involved in amino acid transport across the membranes, found mainly in the biliary ducts of the liver, kidney, and the pancreas. Enzymatic activity is induced by a number of drugs and particular alcohol. See, remember this line. Sometimes, last time one student asks a patient to lie with history. Yes, sometimes the patient lie. We have some. We should use our smart idea or knowledge. Suppose you ask a patient, do you drink alcohol? And they denied, no, we never drink, no, we never drink. But you are sure that patient is drunk, but still they are lying. That time you can measure this gamma GT or gamma glutamyl transferase, and the alcoholic patient or drunk people, they have a very, very high amount of this gamma GT enzyme. Even suppose you have some party or celebration, that time you drink some, and the day after tomorrow if you measure your this gamma GT will be high. It's not about chronic alcoholic user or acute. It depends. Even sometimes you are very social drunk, or occasionally you drink. Suppose in some festivals or some occasion, that time even it increase. That's why sometimes these tests or markers also help to find out the truth about the patient. Gamma GT increased in liver disease, especially in obstructive jaundice. Yes. In the obstructive jaundice, alkaline phosphatase increase. We know that now another enzyme that increases gamma GT. Gamma GT liver are used as a marker of alcohol-induced liver disease and liver cirrhosis. Yes, if there is a cirrhosis, a type of very, very severe condition of liver disease where very big pouch like structures are seen. If you do the Google, you will see very terrible picture of liver. If you see liver cirrhosis, that time you will see how liver is damaged in cirrhosis. That is very critical or very serious condition due to either viral hepatitis or alcohol or drug induced. Many reasons are there. And after that, gamma GT, next enzyme is 5-nucleotidase. It mortality increase in hepatitis and highly elevated in biliary obstruction. Unlike alkaline phosphatase, the level is unrelated to osteoblastic activity and thus unaffected by the bone disease. That means in alkaline phosphatase, there is a chances of false result because we don't know it's due to bone or due to placenta or due to liver or obstruction. It's very difficult. However, we take very genuine history because age is a kind of history. Suppose a patient is only 15 years, there is chances of health high because of bone. If patient is 65 years, there is another chance of health high. But rather than alkaline phosphatase, if we measure this 5-nucleotidase, it is very related to osteoblastic. It is related to this obstruction, especially biliary obstruction. The enzyme hydrolyzes 5-nucleotidase to 5-nucleotidase at an optimum pH of 7.5. This is a little bit alkaline in nature. That means that the optimal activity of this enzyme is slightly in alkaline medium. And third one, after this, just we learn some biochemical marker about cardiac tissue, then we learn about the hepatic tissue. Now serum enzymes in bone disease, we already know that is alkaline phosphatase, and rises in rickets, osteomyelitis, hyperthyroidism, hyperparathyroidism, also rises in primary and secondary malignancies of bone. Yes, alkaline phosphatase increases. And another enzyme is also the acid phosphatase, highly increased in bone metastasis of carcinoma of prostate. That means if patient have a prostatic carcinoma and that metastasis level, that means it is spread over the body, that is called metastasis. And that time if we measure acid phosphatase, that will be very, very high. These are the other markers which can be used. However, they are bone marker, but when they are very high, they reflect different things, because in metastasis of this prostate cancer ultimately spread to the bone, and not possible to get treatment after that once these cancer are metastatic stage. Then serum enzymes in muscle disease. We are in muscle disease definitely, but cardiac muscle and hepatic muscle or soft muscle we just finished. Now we are in muscle disease. Aspartate transferase. Muscle means, if we say muscle, just remember we are talking about skeletal muscle. Aspartate transaminase not commonly done because it's related to liver, it's related to cardiac tissue. That's why to see the damage of skeletal muscle, we can measure aspartate transferase, but it is not very specific. Aldolase, moderate increase in the dermatomyositis, muscular dystrophies. Highest values are seen in Duchenne type of muscular dystrophies. This is a genetic disorder, congenital disorder. This is DMD, Duchenne muscular dystrophy. It's a very, very serious. There are 8-9 types of muscular dystrophies where we can find very high level of this aldolase. And the CPK, definitely this creatine phosphokinase enzyme elevated in neurogenic muscular dystrophies. Highest values are seen again in DMD, this Duchenne type of muscular dystrophy. Yes, yesterday I was in hospital, and these CPK are generally around less than 125 or 200, something like that. But yesterday I found 6,000 value of the CPK. And when I called where was that patient and asked history to the duty doctor, they said the patient has this muscular dystrophy. Yes, that means we have to find out the history as well. Otherwise, it's very, very difficult to correlate your results, obtain results, because if you have a not clear history, that time maybe there is a problem in your machine or something like that. However, nowadays that is not possible, because before performing every test, the machines are checked by machine themselves and duty technologists or duty staffs. Serum enzymes in GI tract, similarly in GI tract, amylase, yes, especially for pancreatitis, we measure amylase and lipase. Serum activity more than 1,000 units can be seen within 24 hours in acute pancreatitis. Generally, it's less than 100. This amylase to digest carbohydrate. We have a ptyalin in our tongue, lingual lipase. Then it's released from pancreas. This is for the digestion of carbohydrate actually. But when we have a severe form of acute pancreatitis, either idiopathic or alcohol-induced, there are many, many reasons for pancreatitis. That time it is obtained more than 1,000 units. Generally, it is less than 100. The rise in serum activity is also seen in perforated peptic ulcer and intestinal obstruction. Except that acute pancreatitis, it may be high in perforated peptic ulcer and intestinal obstruction. Lipase is another enzyme to break down fatty acids. level are seen in acute pancreatitis, also reported in high in perforated duodenal and peptic ulcer in intestinal obstruction. That means these amylase and lipase can be measured to see the some injuries in GI tract, especially in pancreatic case, or some peptic ulcer or intestinal obstruction. Yes, enzymes is a tumor marker. There are some enzymes, they reflect as a tumor marker. And a tumor marker, some people confused with tumor marker. Tumor marker means they are not reflecting that exactly you